Thank you to the organisers for giving me an opportunity. Those of you who are used to me coming up here for the last 10 years railing about how inadequate the pneumococcal program was will be pleased to know that I've changed my tune for this. The cartoon is the new guidelines from RFK Junior for conducting vaccine trials. Some of you will receive a placebo and the rest of you will also receive a placebo. These are my disclosures. We have 15 minutes to do adult pneumococcal disease, so I want to start with some principles. Pneumococcal immunity is largely serotype specific. Serotype replacement occurs. Continually adding more serotypes can lessen the effectiveness, a concept called downward drift. Vaccinating children protects older persons against those serotypes. Takes somewhere between 4 and 6 years, but we saw it with PCV7 and PCV13. And our pneumococcal vaccine coverage in older people is poor for 3 reasons. The program's too complicated. I have never met a general practitioner that understood the previous pneumococcal policy, 12 pages of it. The program was largely unfunded, while we did have recommendations from the handbook of about 4 million people who should get a vaccine. We funded it for between 8 and 10 people each year, and healthcare practitioners were underwhelmed about the whole process, and so we just didn't give this particular vaccine. We've had discussions from Michael Woodward and others about seniors at risk of several infectious diseases. They don't respond well to treatment, largely because of immune senescence and other issues, and they suffer high rates of mortality and morbidity due to infectious diseases. So we need to prevent the disease via vaccination, and that's where we're going. So immunosenescence, which has been brushed over a few times in the last 2 days, is essentially your body starting to decline. In my 70th year, it's something I'm very familiar with. But from the point of view of immunosenescence, or that combined with inflammation, we see an increase in exhausted memory cells, a decrease in naive T cells, a decrease in CD8, telomere shortening, and essentially what happens is that we get a decreased response to all vaccines as we age. This is familiar to most of the people in the room. What I want to highlight is that progression from colonisation to invasive infection has a disproportionate impact on the very young and elderly. 90% of IPD cases and deaths occur in adults. It's a leading cause of morbidity and mortality globally, and as Sanjay was saying, it's greatly enhanced by the co-infection with influenza A virus, but also with RSV and other respiratory viruses. So in Australia, the ABSRHW statistics for 2019, some of this data is 2019 because the data in the pandemic was really all over the place. 4,000 cases of IPD, 12,000 hospitalisations, 1,128 deaths, and they're largely for IPD because we have very poor data on cases of CAP, and so we really can't enumerate how many cases are due to pneumococcal disease. So this is the new current policy, and we've just had an explanation from Sanjay. From now up to 18 years, PCV20 for everyone. So those of you that are immunisers in the audience, is standardised, removes PCV13, 15 and 23, and it will remove the confusion for general practitioners and nurse practitioners about what happens with pneumococcal vaccine. Everybody gets 20. Sanjay identified that there's still ongoing issues with things like serotype 3, a lot of discussion about whether a 2+1 program is appropriate for PCV20, but in the end the message is This is our program. It's a program that's relatively new and it's unlikely to change further. In older persons, the current program is that we're still using PCV 13 plus minus PPSV 23. There is a review on adult vaccination, which I understand is soon to report. But as I said earlier, at the moment, funding for pneumococcal vaccines for old people is based on an ageist policy that says you must be over 70 or you can be one of very restricted groups. You can have had a cochlear implant or have end-stage renal disease or something similar. Pneumococcal capsules are highly variable, and that's why we have around about 100 serotypes that have been identified, and it's the capsule that is in some way involved with both immunity but also with the severity. So you can see two of them there. One of them, serotype 3, has a much thicker, loosely covalently bound capsule than most of the other serotypes. It's resistant to our capacity to clear it. The capsule tends to separate out in the body, and we spend a lot of our immune system targeting bits of capsules instead of the bug itself. This is the over 70 IPD cases in epidemiology, again, largely up to 2019, because you can see decreases during the pandemic. And what you can see here is that we added in PCV 13 in 2011, and over that period of time we have had an increase in non-vaccine type disease, but we've also still had significant PCV 13-7 disease, which is largely serotype 3, and we've still had some ongoing issues, not large, with PCV 7. Now, this is not in those years being provided to older persons, but this is some of the impact of these vaccinating children on older people. This is the serotype distribution in 2019. You can see still a little bit of 19F. A quarter of the cases were due to serotypes that were actually in the vaccine, PCV 13, and again, the big green bar is PCV, is serotype 3. And then those that were in PPV 23 but not in a PCV are shown in the next. They accounted for 30%. Two of those were targeted by PCV 15. 5 extra were targeted by PCV 20. And there was a couple there that weren't targeted by anything, and then a quarter of cases non-vaccine type. So what do we need for adults? We needed something that worked on serotypes for which vaccine was non-effective. We needed serotypes that have become a problem elsewhere that weren't in PCV 13, in particular 22F and 33F, and they've been associated with significant antimicrobial resistance, not here in Australia, but in other countries, particularly places like Canada. We needed the 5 serotypes that were in PCV 20 that weren't in PCV 13. We needed non-vaccine serotypes, but, as the EMA review said quite clearly, you can't just keep adding to these, although there is a PCV 30 being assessed. The downward drift of continuing to add meant that the individual serotypes we had were less effective, and you saw that in a lot of the immunogenicity data with PCV 20 during the trial. So this is an overview of what's available today. We have PCV 7, which is gone, 13 and 23, which are for a short period of time still available for older adults, 15, which is pretty well gone now that 20 has replaced it. And they're the ones that are currently available in Australia. This is a slide from the recent ACIP discussions, and you can see that there are some new ones on the horizon, PCV 21, and I want to talk about that soon. There are 2 PCV 21s. This is the Merck version, not the Sanofi version, which is PCV 20 plus 9N, and then some of this new technology, GSK, the VAX-24, VAX-31 processes that are coming out from GSK and Vaxcyte. This is actually a gross overrepresentation of what's available, underrepresentation. This is another table of what's coming out at the moment. And you can see that this is really going to be a hodgepodge of new vaccines that are being developed at the moment in different places, some with different technology. And so while I'm telling you what I think we should do today, and I'm hoping will be available after the next tender in the middle of the year, this is going to continuously change as we chase serotype replacement and disease increasing with non-vaccine serotypes. So this is why I think there's light at the end of the tunnel. This is the Merck PCV21 vaccine. I saw that on the stand. They've actually got a thing on their stand today on Capvaxive. And the difference is that we know that vaccinating children with conjugated vaccine decreases disease with most of those serotypes in older adults. And so what this vaccine has said, instead of giving you PCV30 and covering more, we're going to stop giving you some of the ones that are in PCV 7, 13 and 20, and we're going to replace them with serotypes not found in those vaccines. And so what we're going to get is only 21, but we're going to have a significant number of these that are novel and are targeting disease-producing pneumococcal serotypes in elderly people. So this is the data from the US after the June ACIP meeting, and you can see that they've actually had a look at the proportion of IBD by vaccine type among adults with a pneumococcal indication for those 5 years. And you can see that in 19 to 64-year-olds with a risk-based indication, PCV20 covered 58%, PCV21 covered 81%. And in those greater than 65, it was a similar process, a bit less with 20, a bit more with PCV21. So the decision to move away from adding but to start substituting has produced a fairly significant change in what we're hoping will be successful prevention. These are data in 2024 from Australia, and you can see that again in those over 70 years of age, you get a 25% boost with PCV21 and not quite as good, but about a 10% boost with PCV21 over 20. This is what it covers. This doesn't mean it's 100% effective against each of those individual serotypes in there. And you can see that we're saying PPSV23 is very good, over 70 and over 50, but the reality is that it does not have as effective coverage and doesn't have anything like the longevity of the conjugated vaccine. So this is a really important point that we've really ignored to some extent in Australia. The herd effects that come from giving PCV20 to children, as we're about to do, are significant in that they will decrease the remaining disease in the elderly from the serotypes in PCV20. And this is the model data from ACIP at the meeting. And you can see that even by year 4, I've got no idea whether any of this works, even by year 4, 3/4 of the disease in PCV20 is expected to have disappeared from the adult population by then. And so we're going to get some benefit. And I remember the 3-year trial that the US ran when they gave both PCV13 and PPSV23 to older persons, and then made a decision after that to stop using PCV13 in older persons because they weren't getting any additional benefit from what they got by giving PCV13 to children at that time. This is their economic assessment. They're saying that giving 21 instead of 20 increased qualities with a moderate increase in cost. This is the data such that it has been released already from the PBAC meeting in November, and the positives are that they have recommended 21-valent pneumococcal conjugate vaccine for the groups that are listed there. They have reversed the damage done by changing from 65 years to 70 years. So we're going to be able to go back to saying people above the age of 65 years. I mean, I'm a bit disappointed that finally I'm going to get to 70 this year. Now they've reduced it back to 65, so I would have been entitled to it. And they've also now added people with chronic liver disease and COPD to the list. And so this has always been a group that we knew was at greater risk, but it's now a group that we're actually going to fund, whereas previously we did not provide funding for these in the medical at-risk population. So I think there's some real wins out of what's come out of PBAC, which is very similar to what's come out of the US recently. So today the message is the policy is unchanged, that if you're going to vaccinate, you give them PCV 13 plus or minus 23 for older people, medically at risk and ATSI. There will be a tender mid-year, and I'm hoping that a new policy comes out in conjunction with the publication of the review. At the moment, based on the data from Australia and the US, PCV 21 looks the best option for older people. ST4, which was mentioned by Sanjay, is not really a significant issue in Australia at the moment, but we need to have a look at it. While PCV 21 appears to give us the best bang for the buck, there are many places that use PCV 20 or PCV 21. And if you look at the current US recommendation, it is to give 21 or 20, or if you can't get your hands on one of those, 15 plus 20 PPSV 23. So one of the issues with PCV 21 is that it does not have serotype 4 in it. And in the US, on the west coast, in Alaska and down the west coast, Oregon, California, it's now getting to about 30%. And so the policy in the US is that you should use PCV 21, but if your ST4 is getting towards 30%, you should consider using 20 instead, because you'll get protection there, which you won't get by using 21. So lots of numbers, lots of confusion, but actually some clarity coming to our policy. 20 for everybody and up to 18, and watch this space. I'm hoping a much simpler and more effective than our current program will soon be available for adults as well.